as we know that if we talk about the atrial fibrillation, so definitely this disease is globally one of the prevalent disease, having the incidence rate of around 2% approximately. So what is your take on that? Because still it seems that it is one of the under-detected disease, and you must have seen many patients with atrial fibrillation during your practice and during your clinical experience. So what is your take on that? Whether it's what are the diagnosis rate is there, whether it's appropriate or it's under-detected, and how we can improve on this particular part as well?
Sure. Well, the global prevalence of atrial fibrillation has been, at least we have the data from US and Europe, so 2% they say. And though we are a large population in India, but we don't have specific incidence and prevalence of atrial fibrillation. But I must say, we have some West Birmingham Cooperative Registry data, which says that in this registry we have only 0.6% of atrial fibrillation. So, but of course, this is definitely not the true incidence or prevalence. But as a practitioner, as a cardiologist, I must say definitely Indians have a lot of atrial fibrillation, which is truly really undetected. Like it's like a tip of iceberg what we see, and the patient comes only when they are symptomatic, and especially poor patients, they come when at the stage of complications. So definitely in India it is underdetected, and it is more prevalent than what is described in the literature. And I must say, at least I can say because India, it's a bit of underreporting is especially in relation to non-valvular atrial fibrillation, is because we have more of rheumatic atrial fibrillation. So usually at young age they seek medical advice because of rheumatic fever and then related complications and valvular disease. And atrial fibrillation is a part of that rheumatic valvular disease. So non-valvular rheumatic, non-rheumatic atrial fibrillation or non-valvular atrial fibrillation, it is truly underreported. In India, I feel it is definitely more prevalent. And yeah, that is true.
Okay. So, sir, as you mentioned very well that definitely in India, the rheumatic condition is a very one of the prevalent condition from childhood, and the patients are getting a valvular deformity at later age on. So this is currently what we have also seen, that there are so many screening studies are also going to happen in a western part of the world, so that they can detect the AF patient, whether it's non-valvular, because in western part definitely non-valvular is a more prevalent than the valvular part. So they have so many registration regarding the screening part of the atrial fibrillation. So what is your opinion on that? This kind of the screening registries and the screening program, should we have in Indian perspective also as well, so that at earliest level we can detect the AF cases at appropriate time?
Certainly, because I just say one group. I am a visiting professor to Kathmandu University. I take the country of Nepal as as a small country where we can have the true data, and probably we can extrapolate the same data because it's almost neighboring country to India. And in our study, probably first study in that part of the world, and maybe it's equally true in Indian statistics as well. So what we find in our study was this atrial fibrillation in relation to structural heart disease, yes, and then non-structural heart disease. So overall atrial fibrillation, it is 35 to 38% is related to rheumatic valvular disease, and 30% is related to degenerative valvular disease in elderly patients, like calcific aortic stenosis, calcific mitral valve disease, and some 20% related to cardiomyopathies. Lone atrial fibrillation or non-valvular atrial fibrillation, where the heart is structurally normal, is probably it comes around 10 to 20%.
Yes. So
probably I can say this can be the same in India as well. So some 10 to 20%, low atrial fibrillation or non-valvular atrial fibrillation. But at least we can see in India as places equivalent to developed countries and underdeveloped. I mean, poor. We have the two extreme cohorts. Yes. So in still the rural area, rheumatic and other valvular diseases, they prevail atrial fibrillation, and in cities, metros, especially developed states and developed cities, they are on par with developed countries where the non-valvular atrial fibrillation is at least increasing rapidly.
Yes.
So, and relevant to how best we can detect and diagnose. The thing is, we have at least most of the educated people in India, they have the tendency of having checkups, annual checkups, yes, health checkups. And of course, in rural areas, it is our, it's both, professional from the doctors as well as from the policy makers that, we need to identify the patients and then make a database and then register. But sometimes patients, most of the rural population, they come with the symptoms, yes, not just because they have atrial fibrillation, because of the heart disease. So maybe chest pain, breathlessness, maybe syncope, or with established complications like stroke or any embolic phenomenon. So then atrial fibrillation is accidentally diagnosed.
Retrospectively.
Correct, retrospectively. And yes, in an asymptomatic patient, so at least from our professional side, the maybe tertiary care hospital at least, what we suggest and actually we are doing is making a registry database, and patients with non-valvular atrial fibrillation or lone atrial fibrillation or only atrial fibrillation without structural heart disease. So definitely we are lacking through registries, through data, incidence and prevalence, and how best we can detect. It's simple. It's very simple. It's the most common arrhythmia, yes, and all arrhythmias are best detected by simple physical examination by checking the pulse as well as taking an ECG. Well, if patient says that I have palpitation once in a while and a baseline normal clinical exam, pulse is regular, ECG is normal, it could be any arrhythmia. So the best way to detect is like 24-hour Holter monitor or so even monitors like external loop recorder, internal loop recorder. So in an asymptomatic individual where we suspect atrial fibrillation is the cause of arrhythmia, where baseline parameters are normal, maybe the best way is Holter or even monitors like external loop recorders or internal loop recorders. That's the best way. That's the best way to detect, document, and evaluate for the further proceedings or how to treat the patient. Yes.
Sure. So it's very well said, and even the guidelines are also now suggesting that as a term is the opportunistic screening. When the patient having the age of something like more than 65 sure, years, then at least what you said, that is a basic pulse palpation method, and ECG it should be the part of your diagnosis. Then apart from other cardiovascular disease, if patient have atrial fibrillation without any symptoms, then definitely it can be detected on that time and the treatment can be started simple, as soon as possible.
Correct. It still ECG is an indispensable tool. Simple physical.
No doubt about that. Yeah. Surely.
Yes.
So definitely. So now, sir, if we go about the management part, so as we know that in AF, rate, rhythm control, and apart from that, the prevention of complication is also very, very important, like a stroke prevention, yes, atrial fibrillation. So since almost 1950s, the VKs and the older oral anticoagulants, what we can say, they are available, and still they are the gold standard treatment. But now since last 4 or 5 years, we have seen the newer generation of oral anticoagulants are available. So sir, in your practice, how do you have differentiate both the molecules, and what the challenge you have found with the VK, so that you made this your decision to shift in some patients to the oral anticoagulants to the newer oral anticoagulants?
That's great. Because especially after 60 years, the European database or registries say that after 60 years, the prevalence rate of AFib is high, and especially maybe even in India, after 40 years, I can say, based on life expectancy. And we all know that, any patient with atrial fibrillation has 4 to 5-fold increased risk of stroke. So definitely, it's in a patient, ischemic or hemorrhagic stroke sometimes in relation to atrial fibrillation is definitely underreported, especially in the remote areas in India. So, treatment is also challenging, especially where we have all sorts of patient groups, structural versus non-structural heart disease. So, the legendary star molecule, nearing 60 years or so. So, we know well about, coumadins, warfarin, acinocomerol and all. So, I must say that has been only drug till a few years back. So, where we have to prescribe and then test the patient for PT and INR and compliance. Of course, everybody and any doctor who prescribes these vitamin K antagonists knows that. So, there is a double-edged sword. So, it is a good drug as well as it is a bad drug in the sense that, so compliance and then the side effects. So, we all know that patient needs to be monitored at least once in a month, and because the therapeutic window is very narrow, it shouldn't be the INR like 2 to 3 exactly, and less than that is ineffective, and more than that has high bleeding risk. And even if you stop the drug, because it's long, half-life is long, up to 40 hours. So, the effect takes long even if you stop the drug to control the bleeding. And testing these PT test INR with good quality in remote areas and is truly difficult, and compliance of the patient not more than 20 to 30%, especially in rural areas. So, certainly we do face a lot of problems by prescribing these warfarin and or acetrom, but still there is no go for a village patient who wants to get the tablet in a PHC, and that has to be prescribed. And we warn them, of course, like they are the potential. So, it has a lot of drug interactions, a lot of food interactions, a lot of and compliance issues, and then of course bleeding complications. So, definitely it is a good drug, and the advantage is it's effective and it's a well-known molecule, more than half a century. So, but of course we do need, say, if there is any drug with us which can bypass all these adverse effects, like short duration of action, like for example 24 hours, it should work for 24 hours with single dose, and no need of testing or monitoring, and it should be affordable. So, all 3 years it should be effective, efficacious, and then economical, and it should be available. It should be easily available. So, if every practitioners who treats atrial fibrillation certainly dream about a molecule like this. It's good that we have NOACs in this decade, that we started treating atrial fibrillation with these NOACs. So, though of course they are newer molecules, but they are well proven in clinical trials that they are really effective and certainly non-inferior, and to some extent some drugs they are superior to warfarin with less complications. But we do welcome that. Maybe their long-term stay and safety, maybe we need to wait for the time.
So, definitely sir, during your discussion what you have mentioned, one point is very correctly regarding the compliance issue, because as we know that when the patient have the atrial fibrillation, the treatment will remains for a lifetime for prevention of a stroke, because at any point of the age without treatment patient has a very high chance to developing the stroke. And as you also mentioned that Vicase, warfarin, acetrom, these drugs are available since last almost 50 to 60 years, but still the practical challenges like PT monitoring, INR monitoring, which is not willingly done by the patients, and that's why the compliance remains low, around 25 to 30% at the end of the first and second year. So, sir, what do you find that even also you mentioned that is if the drug is available as a once daily dosage without monitoring, without INR monitoring is required, and it's proven efficacy and proven safety. So, sir, in NOACs part, we have as of now 3 drugs in India: rivaroxaban, dabigatran, and apixaban. So in that, if we say the once daily, like the rivaroxaban is once daily, dabigatran and apixaban has also advantages in some other part regarding the ischemic stroke and regarding the GI bleed. So all three NOACs are available. So how will you position these all three NOACs in your clinical practice? When if you want to prescribe a NOAC, then how will you position these three drugs?
Certainly, NOACs, they have proven, they have established, at least in treating the non-valvular atrial fibrillation, at least they have proven, they have established their role and stand in treating this. I must say, because all of them, they are compared to warfarin. It's not head-to-head comparison. And so warfarin comparison, they've compared. So they all the three drugs, that's dabigatran, which is direct thrombin inhibitor, and the factor Xa inhibitors, apixaban and rivaroxaban. So for me personally, because I have a little experience of using all the three drugs past few years, I must say all are good.
Yes.
All are good. Maybe say suppose out of 100, the three guys got some 95 marks, 94.5 or some 94.5. Just 1% plus minus this way. Correct. But I must say, after treating the patients and with the available evidence, and after extensively analyzing the publications, the research data, I must say, all are good, of course, and still I want to be choosy. To some extent, though we follow the guidelines, so what is my aim in treating this patient? Based on that, I choose the molecule. So what is his CHAD score, CHAD-SWAS score or Hasbled score, and whether he belongs to the stroke risk, whether low, intermediate or high risk of stroke, and other comorbidities like whether patient recently underwent stenting or MI or heart failure. So I consider overall, not just atrial fibrillation, because atrial fibrillation is only the tip of the iceberg.
Yes.
It is rather a syndrome, That's why we not only see the atrial fibrillation, we see a lot of heart failure, diabetes, renal, and everything. So in treating atrial fibrillation, for me, in summary, all the NOACs that are available, they're all good, and they've been proven in efficacy, safety-wise as well, with no need of monitoring. The best part is they don't need monitoring as of now. And of course, even antidotes have come up in case of overdoses. So I can put, of course, within the range of 0.5 to 1% plus minus. So all are equally good.
Yeah, definitely. So as you mentioned that there is no, as of now, head-to-head trials are available. So it's very difficult to judge anybody who is superior and who is equal and who is non-inferior, definitely. But as you mentioned very well that even if we have taken the feedback from other practitioners also as well, all three are as of now good. Some have some minus points, some have plus point. But if we see the overall, all three drugs are almost safety and efficacy wise, they are very good. So sir, this is just a last question for you. That's as you are interventional cardiologist, so you must have many patients for the acute coronary syndrome.
Yes.
So that patient after the post-stenting or any kind of bypass grafting, they might be developing a atrial fibrillation, because in this kind of condition, the chances of AF development is very, very high.
Correct.
So now this is a catch point there. As of now, there is no any established data that patient having AS and AF, then how the noise can be used, or even warfarin can be used along with DAPT. Yes. Because the DAPT is a must when you are doing the stenting to prevent the stent thrombosis and recurrent of MI. And now for the part of atrial fibrillation, if you want to add any kind of oral anticoagulants for say NOACs like rivaroxaban, which is proven for the ACS also as well. So how this is even ESC guideline also suggested something is like that you should continue with the DAPT, then you can follow with the OAC for a lifetime. So what's your consideration is that? Because still it's one of the gray area what we found that how we can discuss with the other doctors also as well. So
this is a very, very important question, and they're the situations where we face day to day in treating patients, because we not only treat atrial fibrillation. It's not just atrial fibrillation what we need to treat. It is a complex patient in the complex situation, in the clinical scenario, the real world scenario. So that's where we need to face a lot of challenges. like because the trials screen only nice patients for the inclusion criteria and exclude at least in the initially to for the safety data. So, but in real world we need to face a lot of problems in treating patients. Well, I can say rather I can summarize like this. See, what your patient needs exactly is just non-valvular atrial fibrillation with a high chance of stroke, like high score, high cumulative score of CHADS-VASc, and versus low to intermediate or intermediate to high young patient with multiple risk factors like what you said, acute coronary syndrome. So, it's not just my own thing, it's based on the evidence I can say that, see in the real data, the dabigatran has shown a little bit. So, they say statistically not significant, and even FDA has an alert on that, and there was some more investigation went on. So, to analyze this data of a little bit of high incidence of MIs after using dabigatran. But they say statistically, so they say 1 in somewhere between 470 patients, one coronary event. But there is of course a trend of increased MI or ACS in patients on dabigatran. And apixaban, maybe I can say it's neutral or maybe effective. But this Rocketeif has clearly shown that there will be 16% reduction in cardiovascular, especially MI related events, risk, and it has even proven the mortality benefit. Mortality benefit specifically in relation to ischemic, that is MI related event. So 16% reduction. So maybe in relation to your question, like if a patient of ACS who needs NOACs, so definitely I can prefer rivaroxaban in that, because we have the data or evidence to say that rivaroxaban is effective in ACS. Rather, it lowers the incidence of ACS, those who are already on it, and if already patients on dual antiplatelet developing atrial fibrillation, based on current guidelines, they say first thing is we need to risk stratify, whether it is moderate to high risk of having stroke. Then we have to use with dual antiplatelets with NOACs, preferably rivaroxaban, at least 4 to 6 weeks. Okay, at least 4 to 6 weeks. If it is high risk of stroke, or bleeding, not only stroke, high risk of bleeding as well. Here, what is important is Has-Blood score. If Has-Blood score is very high, the patient may bleed at least more than 3, 4 Has-Blood score. So then 4 to 6 weeks of dual antiplatelet with NOACs. Then later on continue with one antiplatelet with NOAC for a year, and then decide later. Provided patient is having low to intermediate risk of Has-Blood, so bleeding chance, maybe up to 6 months we can use dual antiplatelet with NOAC, preferably rivaroxaban, and later we can decide like with NOAC with one antiplatelet up to a year, and then decide, risk stratify. So this is based on the current guidelines and then evidence. So simply if Has-Blood score is high, use it for 4 weeks, and then decide with one antiplatelet and rivaroxaban. If it is low risk, you can continue dual antiplatelet with rivaroxaban up to 6 months, and then after 6 months, one antiplatelet and rivaroxaban up to 1 year, and then decide later. So we need to know the CHADS-VASc score, Has-Blood score, and the risk profile of the patient. And definitely the bottom line is, in the setting of acute coronary syndrome, as an interventional cardiologist, I definitely prefer rivaroxaban.
Yeah, obviously, because prime disease definitely it's a SVS. So definitely, sir, if now lastly, what we have discussed regarding the atrial fibrillation, its screening issues and the weakest challenge is the NOACs, beneficial, but they have also some own concern, and regarding the ACS and AF part. So if from your side, if I want to summarize this discussion in just 5 bullet points, then how will you, from your side?
So there's no doubt that atrial fibrillation needs these magic bullets, and definitely they are going to be prescribed more, a lot in future. I can say, I can summarize all the three NOACs. If your aim is to reduce the risk, stroke risk alone, stroke risk alone. If your aim is to reduce stroke risk alone, and including intracranial bleed, maybe we have dabigatran. If we don't want bleeding risk more, so patient has high chance of bleeding.
Yes.
So you want just to play safe.
Yeah.
In between,
Yes.
maybe apexaban. And if you're really patient compliance issues,
Yes.
like I cannot take more pills, only one pill, and I don't want monitoring, and any risk category, because Rocket has shown, it is the only trial that has shown a 3.5 CHAD score.
Yes.
So at least moderate to high risk stroke risk, CHAD-SWAS risk. And patients, especially for a cardiologist, where we do a lot of interventions, where cardiac patient is there, apart from atrial fibrillation, and patient doesn't want more pills, and it is definitely safe. So I prefer rivaroxaban, certainly.
Sure.
So that would be my summary to conclude. Yeah.
So, sir, definitely, we are very grateful for your all thoughts and your overall opinion, and what is your the discussion part is that definitely it's very helpful for us that we can take these suggestions to increase the awareness of regarding the atrial fibrillation, its management, its the screening part as well, to the further medical fraternity as well. So, Dr. Guruprasad, it's very thankful to you, and it's my pleasure that you have come to this particular show and providing your time. So, thanks a lot.
Thank you very much. Thank you.